Welcome to the third webinar series on the importance of integrating general and oral health. This series is brought to you by the World Federation of Public Health Associations Oral Health Group. And my name is Professor Raman Bedi, and I will be co-chairing this session today with Professor Alan Minglung Tsu, who is joining us from Taiwan. Next slide. We would like to say thank you to our sponsors, the University of Geneva, the charity, the Global Child Dental Fund, Colgate-Palmolive, and the Taiwan Dental Association. This webinar will be archived and placed on social media, including YouTube. And we're grateful to all the speakers who have allowed their slides and this recording to be shown freely available. Next slide. My name is Professor Raman Bedi. As I've said, I was the Chief Dental Officer from England and presently the Chairman of the Global Child Dental Fund. I'm also Chairman of the Oral Health Group, and we have worked very hard to bring together a whole series of issues on global oral health. Next slide. Co-chair is Professor Alan Minglung Tsu, who will be introducing himself and the other speakers shortly. Alan is well known as a dean of a major university, dental school in Taiwan, the National Yang Ming University, and he's also president of the Dental Education Group of the Asian Pacific. Next slide. We have on our panel Professor Bruce Donoff of the Harvard School of Dental Medicine. Bruce has been Dean of the Harvard School of Dental Medicine for a number of years and has been leading the initiative on how to integrate general and oral health, particularly in the United States context. Bruce is unable to join with us, but he has kindly provided a video of his presentation, and that will be shown shortly. Dr. Tu-Chi Chu is at the International Union for Health Promotion and Education and is the Global Vice President of Capacity Building. Professor Mahesh Verma was the Dean of the Dental School there in Delhi, but now is the Vice Chancellor of the Guru Gobind Singh Intraprastha University in Delhi. Mahesh is one of the few dentists who become a Vice Chancellor of a major university in India and is one of the few dentists to be invited to serve on the board of the General Medical Council. Dr. Mengistu Anatsnak is the country coordinator of Pathway International Ethiopia, but he's also a former president of the World Federation of Public Health Associations. Professor Bettina Boesch will be joining us and is at the University of Geneva as a professor in global health, but she's also currently the CEO of the World Federation of Public Health Associations. Next slide. So Bruce Donoff, who I said cannot be with us, but has kindly video called his presentation, and we'll be showing that now. Okay, we have Dr. Chu afterwards, and then Professor Verma. And if we go to the next slide. And now the next slide, please.
Good day, and I'm very pleased to introduce a topic that is very dear to my heart, and that is integration of oral health and medicine. It's interesting in that there has been growing interest in this area. As you can see on this slide, at least in this country and around the world, interest has been expressed by the Institute of Medicine report in 1995, the first ever Surgeon General's report on oral health in 2001, a recent 21st Century Guys report done by the American Dental Education Association, a roundtable report on integration of oral health and primary care by our National Academy, There's now in the works a second Surgeon General's report. The Santa Fe Group has had an initiative to get Medicare dental coverage for a while. Last year, a group of senior professors and dentists issued La Cascada Declaration that suggested that dentistry and medicine should get back together again where they first started. And only this past July, The Lancet had 2 articles on oral diseases, a global public health challenge, ending the neglect of global oral health, that it's time for radical action. And one of the actions, the next slide, please, was integration. So I'll introduce this topic with a favorite story. Atul Gawande, who's a surgeon here in Boston, had a paper in an article in the New Yorker some years ago called Slow Ideas. And he talked about how the introduction of ether anesthesia in 1846 compared with the adoption of asepsis by Lister in London. Ether anesthesia was adopted like wildfire. You thought there was an internet back then. It was communicated so readily. But asepsis and sterility didn't gain widespread acceptance very quickly. The reason for that is ether was good for the doctor. It let them do things they couldn't do before. Asepsis and sterile technique really was work and meant creating new systems to create sterile environments, etc. And the same probably is true about dental implants and HIV/AIDS. Dental implants, when introduced in the early 80s, caught on like wildfire. HIV/AIDS was a detriment to the profession, with many people worried that they were seeing patients who had a death sentence attached to them who would come into their office and not tell them about that. And I think integration of oral health into general health is also a slow idea. It's been going on a long time. The next slide, please. So the Lancet recommendations that just came out and can be found in the journal itself suggested that one should improve epidemiology and oral health surveillance systems, reform of oral health care systems, education and training of the future oral health workforce would be a very important issue, tackling oral health inequities all over the world, moving upstream to maximize oral health improvement, addressing commercial determinants of oral diseases like sugar drinks, advancing research agendas, and amplifying global advocacy. I must say that with all the things, all the reports that I mentioned before and now the Lancet recommendations, my bias is a lot of words and we need more action. How to do that action is very difficult given the differences in countries around the world and even in our own country where we have some leverage doing it with different states. The next, please. This is some big picture take and think by the Health Policy Institute of the American Dental Association. This was a guest editorial called Our Dental Care System is Stuck. Marko Vijic leads this effort, and he talked about the reforms needed to drive major expansions in dental care use and meaningful sustained improvements in oral health. One, address the dental coverage gap. There is real problems in terms of access. Define and systematically measure oral health. There are really no outcome measures, and ICHOMS has been trying to do this, and there has been work to create some outcome measures so that value can be determined relative to cost. Tie reimbursement to outcomes, which is very important and hasn't been done, and reform the care delivery model, and that's one of my favorite areas of consideration. I do think that the history of dentistry, at least in our country, based upon 1840 creation of the Baltimore College of Dentistry, really kept dentistry separate. the physicians who started that wanted to be associated with the University of Maryland and its medical school, but that didn't happen. So they developed separately. It wasn't until 1867 when my own institution, the Harvard Dental School, came into being, the first to give the DMD degree, that there truly was association with the university and its medical school. The next, please. John Kotter is a leading business thinker, and I think this chart unfortunately shows how many years we've spent on this and how little we've progressed. So you can see that creating a climate for change, the first three blocks here, are probably where we are now, because we haven't gotten buy-in yet. We haven't empowered action. Maybe we've created a few short-term wins, but we really have a lot of work left to do. The next, please. In 2006, I wrote a paper, It's Time for a New Guy's Report. The Guy's Report of 1926 was a Carnegie Foundation report on dental education that suggested that dentistry in America stay very much aligned with medicine, but separate. And that's the key, but separate. And this has allowed, in my estimation, dental education in our country, and I think around the world, particularly in Europe, where there used to be a system of stomatology, and maybe there are one or two schools left that in fact educate dentists that way, that it's all about procedures. And I think there's less and less critical thinking going into dentistry as our patients age, as our patients have more chronic diseases. And so in 2014, with John McDonough and Christine Reedy on the right, we had this perspective piece in the New England Journal of Medicine that suggested that integrating oral and general health care would be good both in terms of education, in terms of healthcare delivery, because there was some evidence that it could lower costs and improve the health of the population. So what we're really talking about is population health, and there have been some changes that have been part of this. The next, please. This was a report that was just completed last year that was Advancing Dental Education in the 21st Century. This is fondly called the Modern Guys Report. It was led by Howard Baylett, who passed away last year, and Alan Formicola, former Dean of Columbia. And it really takes place in a system of incredible change of healthcare delivery, at least in our country. So CVS, as you see on the right, is merging with Aetna. Amazon, JP Morgan, Berkshire Hathaway is working. There is something called dental service organizations that are 600 to 800 practices where the business side is managed. Values and outcomes haven't been done. There's always the Clay Christensen thoughts of disruptive innovation. Clay has been part of our senior dental leaders. And there are blue ocean strategies. So some things can really change. I realize that around the world, everybody may not know it, but the Ringling Brother and Barnum and Bailey Circus went out of business about 3 years ago, but Cirque du Soleil is thriving. And that's the kind of thinking that I think oral healthcare delivery needs. The other thing that this 21st Century Guys Report suggested is there's been a 47% reduction in the amount of basic science and general health education that takes place in American dental schools. And I think that's very, very upsetting to me and a number of other people. Next, please. So the main issues for change and why integration can help: access and disparities of care around the world, medical treatment of surgical diseases, advanced science. So there's now silver-diamine for treating caries. There are other kinds of research treatments in the works for periodontal disease that has such a devastating effect on diabetes and cardiovascular disease. And although there aren't major direct evidence for this, there's a lot of associative evidence that comes from insurance studies that show that there's improvement in chronic disease management when there's good oral health and there's reduction in costs. Our population all over the world is aging, particularly in the United States, in Asia, and there's increased chronic diseases. And certainly, at least in our country, I do think that some change in the scope of oral health delivery could help relieve the primary care shortage. The next, please. So here are some options for change, at least in our country. Interprofessional education, IPE, is something that's going on, and practice. Many schools include interprofessional education with pharmacy schools, with nursing schools, but very few of them do it with their medical schools. Nurse practitioners and physician assistants have assumed a bigger role in oral health. The Smiles for Life program of the DentaQuest group has been very helpful. In fact, in our institution here, we have a primary care practice in the dental school where students see patients along with physicians and pediatricians and nurse practitioners. The other thing that impacts how dentistry is practiced in our country is practice acts. States have their own practice acts. And so in Illinois, dentists can give vaccinations. In Massachusetts, they can't. Now, how silly is that when dentists give giant needle mandibular blocks but can't give little needle vaccinations? And so practice acts really need to be addressed. Certainly changing education could add basic science and more holistic kind of learning to a dentist's repertoire. And in fact, I think the scope of dental practice could change. In Europe, there certainly was stomatology programs, and in many places, oral medicine frequently required an MD degree as well. Last but not least, I think there is a place for creating a group of champions for oral health and medicine that might require dual degree and unusual residency in either family medicine or primary care, because I do think that having the medical degree adds some clout to someone's standing, whether it be in government committees or state committees or anything like that. The next, please. So we've been working in our initiative to integrate oral health and primary care on something we call the practice of the future. That would be integrated care, that is medicine and dentistry, maybe ophthalmology, optometry, integrated financing, that is medical and dental insurance would not be separate, and which is, historically what's happened in our country, and that we would establish a true interprofessional practice. And this is something we are working on with the Harvard Medical School's Center for Primary Care. We have a lot of support for this through our initiative to integrate oral health and primary care. And we really think that these examples of integration make a difference. It's very difficult to put oral health into a medical school curriculum. We do it here for a day. There have been studies that show 2 hours at most medical schools. There's no reason that this can't be enhanced, and also no reason that it can't be promoted. And that is why I think we might need some new kinds of educational programs. When you think of it, the places where dual degree people exist are in otolaryngology, plastic and reconstructive surgery, all on the surgical side. We need to do the same thing for primary care and medical management as patients age and have more chronic diseases. When I was first in training, there were 2 anticoagulants. Now there are 11. I think that says it all. The next slide, please. So I really do think now is the time, and I look forward to hearing from our other participants, because there's some very interesting differences in Taiwan and India and other places, and I'll look forward to seeing the webinar when it's there. So thank you very much.
Good. Alan, I'll hand over the chair to you. Okay, we're just having a little difficulty about the muting. So if we could unmute Alan, please.
Okay. Thank you, Raman. The next speaker, Professor Qiu Shuti, and she is a Global Vice President for Capacity Building and the International Union for Health Promotion and Education. And he is President and CEO of Health and Sustainable Development Foundation. And she is also the chair for Task Force on health promoting hospitals and age-friendly healthcare, and the former chair of government board and the immediate past director general. And Professor Qiu, today her topic is creating synergies between oral health and the general health. Together we are stronger. Please.
Thank you, Alan, for your kind introduction. Yes, indeed, together we are stronger. Next slide, please. I will talk about the newly released Taiwan Declaration, and I will show you the relevance of the Declaration for health promotion. And also, I will show you some examples from Taiwan regarding how we create synergies between oral and general health. Next slide, please. This is the Taiwan Declaration on the Integration of Oral and General Health, signed on April 29, 2019 in Taipei. It contains 4 parts. The first is the preamble, followed by 6 facts and 6 priority actions, which we recommend to strengthen the integration, and concluded by 3 near-term activities. And when it was signed here, you can see this picture. Bettina was there, Ellen was there, and Raymond, I think you were there too, and together with our Minister Chen. Next slide, please. I will show you more details about this declaration. So in the preamble, it said that oral health is as important as all other aspects of general health. Nevertheless, oral health is frequently separated from prevention, primary, and specialized medical care. And oral health actually shares risk factors with other non-communicable diseases and presents the same inequality and systemic issues. The most vulnerable in the population being the least served, and oral health actually coexists with occurrence and consequences of non-communicable diseases and other health issues, as you have heard from Bruce. Next slide, please. So there are 6 important facts. First, oral conditions rank among the top 10 highest healthcare expenditures when compared to other NCDs. And second, oral health is inseparable from general population health. Third, oral health presents shared risk factors. And fourth, oral health itself is also a risk factor for the development and exacerbation of other non-communicable diseases and other problems, such as diabetes, cardiovascular disease, osteoporosis, aspiration pneumonia, etc. And actually, public health as well as oral health promotion, like prevention and control of NCDs, requires a life course approach for all ages. So we target the same population along the life course, and we should do it together. And promotion of oral health and prevention and control of NCDs via public health measures will mutually benefit each other and integrated actions will lead to best results in improving population health, reducing health gap, and reducing healthcare spending, very importantly. Next slide, please. So there are 6 priority actions we recommended, but there is the B+, the 7th, which I personally also think we should include. So what are the priority actions to strengthen the integration? I will briefly go through, but then I will show you what does it mean, each one through Taiwan's examples. So first, we hope we can apply a health and oral health in all policies approach when we are developing whole of government and whole of society actions, especially when we are doing the health impact assessment in developing these policies. Second, we should integrate oral health screening, prevention, and promotion into the planning and delivery of primary health care to assure equitable and holistic provision of oral health for all. Because for one person, we need whole body health plus oral health for everyone. But we need to have some way of delivering oral health for all to our population. And so we think that primary health care should also consider oral health. However, perhaps when we are delivering oral health, perhaps we can also consider general health. This is the B+. Next. And the third recommendation is to integrate oral health into health promoting activities and health promoting settings, not only in clinical services, but also in settings. And the fourth recommendation is to integrate oral health into holistic health and vice versa in professional education, training, and research. And the fifth is about the collaborative legislative action. And the sixth is about to demonstrate syndemics of the both and the social economic factors throughout the life course in the public health, education, training, policy development, actions, and evaluations. So we work together in our education, training, and research, but also when we are teaching and training the future policy makers, we should also integrate, show them these syndemics and these synergies. Next slide, please. And following the declaration, 3 near-term activities have been identified also in the declaration. First is to develop advocacy in Asia-Pacific region. Second is to develop thought leadership through global webinars and annual policy meeting. And third is to foster implementation via an action plan tailored to each country's context. Next slide, please. So some examples from Taiwan. Next slide, please. Let's start from policy development and legislative action. For example, when we were planning to raise our sin tax on tobacco, we included the cost of oral cancer and periodontal diseases into the calculation of economic burdens. And then we worked together in the advocacy and lobbying. And after we successfully raised the sin tax, we allocate some of the revenue to invest in oral health. In addition to invest in general health, we invest both. Next. So what did we invest? We prioritize those actions which are evidence-based and can address social determinants of oral health. For example, we provide application of fluoride varnish and gels for free biannually to children under 6. And for example, we provide dental sealants application for molars to all the grade 1 primary school students for free. And for example, our country approved fluoridation of salt together with iodinization of salt. And recently, we would like to ask all the school lunches to use salt fluoridated salt. And then also we appoint dentists in remote health centers. So in the primary care center, there are physicians and there is also dentists. And all these have the budget coming from the syntax. So you can see the synergy. We work together and then we invest together. Next slide, please. So how about clinical services? For example, for children, in our well-child examination, we integrate and highlight oral checkup, education, and application of fluoride gel. And in the children's health booklet, we highlighted the dental care together with immunization and newborn screening. You can see how important it is. So each caregiver has this booklet, and each healthcare provider will check this booklet. And when there is any missing visit to dental care, the pediatricians and nurses are encouraged to remind and refer caregivers to visit dental clinics. Next slide, please. For adults, actually 20 years ago, when I developed diabetes practice guideline, we already included a dental exam in our package for the newly diagnosed diabetes patient. And currently, our National Health Insurance has this pay-for-performance scheme for diabetes care. And in this scheme, the package also continues to include oral examination for all the newly diagnosed diabetes patients. Next, we see it as an integral part of quality diabetes care. Next slide, please. And actually, for the most common risk factor in Taiwan, smoking and betel nut chewing, we implement a health promoting hospital model. So every physician, when they are seeing every patient, they should assess the patient's health needs, including the assessment on smoking status and betel nut chewing status. So every physician is also looking at oral health risk factors. And afterwards, if the patient is a smoker or is a chewer of betel nut, then the physician is encouraged to give brief education and to refer this patient for oral cancer screening and for smoking cessation. And for the screening, actually, eligible providers include dentists, otolaryngologists, and some trained physicians. So we work together on oral cancer screening. And for smoking cessation, who are the eligible providers? Not only the trained physicians, but also the trained dentists. So you can see dentists work together, and dentists contribute not only to oral health, but also to general health. Next slide, please. And yeah, so these are just some pictures. Let's move to the final slide. Next, please.
Please.
Yeah, and next. So we quickly improved in our screen rate. The next slide, please. And we reduced our oral cancer mortality rate. Next slide, please. And we look at the performance on screening of different types of profession. You can see actually dentists perform very well. Next slide, please. Also, and in every kind of settings, for example, the nurseries, the schools, the long-term care institutions, and also the prisons, we include dentists into these settings and the dental health, oral health promotion into these settings. But we hope that in the future, the health promoting workplace can also emphasize oral health promotion. Next slide, please. Okay, so this is the slide showing you that actually WHO for oral health promotion, they also emphasize the risk factor approach, upstream approach. And we should emphasize legislation, fiscal measures, taxation, and organizational change as those examples which I have shown you. Okay, next slide, please. So if we apply the health promotion model, the Ottawa Charter with 5 strategies into health promotion, you can see we can do, for example, we should build healthy public policies such as legislation, to ban marketing of sugary drinks and to impose sin tax on sugary products. And we should create supportive environments, and we should strengthen collective actions such as brushing your teeth all together in the kindergartens, after lunch, and in the schools. And for example, we should also emphasize enabling personal skills to demonstrate and check correct toothbrushing skills for everyone, especially for the children, since when they are young. And we should reorient health services. For example, we have outreach, fluoride application, and oral health education into the kindergartens and into the schools. So these are the examples we can apply health promotion model in the settings and in policy making all together to build a better future. Next slide, please. And Bruce mentioned the commercial determinants of health. Yes, let's start from commercial determinants of health. If we did not do anything, those commercials, those marketing of sugary drinks will create a lot of problems. This is the vicious cycle. Because of time, I will not go into the details. However, if we do the upstream approach, starting from healthy public policy, if we include the expenditure into impact assessment and we successfully legislate the ban on promotion of sugary products, etc., then we lower the consumption and we save money and we can subsidize healthy foods and health care, and our children will have higher intake of vegetables and fruits. They will have less calories, less obesity, less diabetes, etc., and higher productivity of the society, and reduce health inequality in the future. Next slide, please. So you can see it's the beautiful synergy we can work upon, and we can turn vicious cycle into virtuous cycle. But the key point is we must work together. Thank you.
Yeah, thank you, Professor Cho. Actually, it is very impressive. I have to show our sincere appreciation to Professor Cho, because she has done a lot to integrate the oral health to the public health in Taiwan. I think not only in Taiwan, this is a very good model for the integration of oral health with the public health. Thank you, Professor Cho.
Thank you.
Yeah.
Good. Well, thank you both very much for that. Can I have the next slide, please? Professor Mahesh is the Vice Chancellor of Guru Gobind Singh Intra Prasad University in Delhi. Mahesh sends his apologies. He is stuck, I think, in a taxi from one meeting to join us, but obviously traffic in Delhi has its own mindset. So I'm going to be a second option, and I will walk through the slides that he presented. Next slide. Mahesh introduces the concept of oral and general health, and that's been covered by our last two speakers, showing the integrated nature of general and oral health. Next slide. And of course, as we know, the common risk factor is shared from oral health with cardiovascular, cancers, obesities, diabetes, and many others. So we are joined at the hip with all those diseases, and we share the common factors of tobacco, alcohol, and invariably diet and lifestyle issues. Next slide. The key thing in the context of India is that dentists need to be aware that a large number of their patients who attend for dental factors also have other diseases. So Mahesh highlights that 58% of people visiting the dentist also show evidence of major cardiovascular disease. Next slide. India also has a very high level of diabetes, and so many of the patients that are seen for diabetes have high levels of poor oral health, and of course many dental patients also have not only coronary heart disease, but also diabetes. So therefore, an integrated approach is just a natural thing to consider. Next slide. Oral cancer is also mentioned by Suchi in Taiwan, and India also has a major oral cancer issue from smoking and also smokeless tobacco use. Betel quid chewing is also problematic. And so oral cancer, like in Taiwan, needs an integrated approach for both all health professionals. Next slide. So India is facing an increasing issue of oral health burden. Increasing numbers of people with cavities, as opposed also people having access to visit a dentist. The last aspect of this slide highlights that only 12.4% of adults have visited a dentist. Next slide. So the oral health services in India are basically restorative basis, and the lack of oral health awareness in the population, lack of visiting of dentists, all makes it very difficult, and therefore naturally other health professionals need to be involved, and there's a strong case for integration of to actually address the oral health burden in India. Next slide. So the India is broken up into states, and each state has its own strategy and dental care services. There's obviously a strong private primary care sector in the urban and semi-urban, but rural areas are poorly served. And so there is the role of mobile dental clinics, particularly in India, reaching the underserved. Next slide. The current status of India at the moment is that they have had an oral health plan, a national one, in 2014, and this is being revisited at the present time. Access to dental care is made through a number of clinics spread throughout India, but the large degree of care is provided in the primary care sector, but this is predominantly in urban and semi-urban areas. Next slide. So the strategy of the national program is based, like Taiwan, on prevention, issues around school-based education, looking at pit and fish sealant programs, fluoride varnish toothbrushing programs. But there's also higher level legislation against tobacco products, the banning of smoking in public places, and the consideration of advertising to children with regard to sugary products. Next slide. So at the moment, from the Indian Dental Association, there's quite a lot of work about dental awareness, remembering the fact that just over 12% of individuals have access to dentists. So there is a good deal of action needed in the awareness. And so the beginning of the National Oral Health Plan is to begin to give education through televisions and through radio. Next slide. India has a mobile strategy of dental clinics, and this is predominantly around Delhi and the larger cities, tier 1 cities. And this is again to promote understanding about oral health and to do some preliminary screening. Next slide. The school-based programs are there, and initially starting as a dental project, but increasingly there is integration of using school-based program in an integrated way. Mahesh actually spoke about this in the webinar on toothbrushing, which was screened just a few weeks ago, and he showed how outreach programs now are integrated with psychiatry, general health screening, as far as oral health screening. Next slide, please. So material is developing at schools, and again, there's an integrated health promotion strategy particularly around tobacco and smoking, and then of course including also diabetes and general poor oral health. Next slide, please. So India has a difficulty with a large population, very dispersed, urban, rural issues, and its workforce. But it does have one of the largest dental workforces and general medical workforces in the world. And integrating those together is one of the major challenges for the universities. Next slide, please. So a number of groups are working to bring together an integrated approach, particularly around NCDs. And these bodies are ranging from mental health to care of the elderly to the oral health program. And so it is at the federal level that they are trying to integrate, but the challenge is always implementation at the local level. Next slide, please. So the point to remember is that India has high levels of diabetes, cardiovascular disease, and oral cancer. And these can only be addressed through an integrated approach with general and medical health. Next slide, please. And Mahesh actually leaves this African proverb, which I think is very poignant. It's, if you want to go fast, go alone. If you want to go far, go together. And I suppose that should underline the whole DNA of what we're trying to say in the integration debate. Thank you very much. Next slide, please. Good. Alan, I will hand you over now to introduce Bettina.
Okay, thank you. It's my great honor to introduce Professor Borish, Bettina Borish. And Bettina Borish is MD, and he got his histopathologist, and she's now the...
Alan, can I just stop you for a moment, because it's my mistake. And I love webinars because we can't edit them, not now anyway. So I should have said it was my turn to introduce Dr. Mengistu Asnak. So I apologize, it's my fault. But I want to introduce actually, before we come to Bettina, a really good friend of the World Federation of Public Health Associations, and personally a good friend, Dr. Mengistu Asnak. Mengistu is the past president of the WFHA and is also the country coordinator of Pathfinders International in Ethiopia. Mengistu is going to share with us the challenges of integration in a low-income country. Mengistu.
Thank you, Professor Rahman, for the kind introduction and coordinating this important public health issue. Well, in dealing with the effective collaboration between public and oral health and prevention, as well as in primary and specialized care, with an emphasis on the importance of integration, specifically in low-income countries, it's very critical to look at the major issues that hinder the access to quality health services. Before dealing with probably major hindering factors, it might be good to define what integrated service delivery is. And as most organizations use, integrated service delivery is probably the organization and management of the different health services so that people get the care they need, when they need it, and in ways that are user-friendly and achieve the desired results and provide value for money. In brief, this definition can be taken as it's providing the right care in the right time and place. And looking at specifically in low-income countries where majority of the people lives far from the major facilities which are providing most of the services, we need to think of different mechanisms how this can really reach the wider population in a country. That's where, for such integrated services, it's very important to really look at the human resource for health, which constitutes the most vital component of the health system. And for countries to meet their health goals and provide integrated health services, it's largely dependent on the knowledge, skills, motivation, and deployment of the health workforce, who are basically responsible for organizing and delivering health services. Different global and country level documentation show evidence of a direct and positive link between the number of health workforce and health service outcomes. And in many countries, specifically in low-income countries, the human resource for health, including oral health professionals, remained very critically low to provide the essential health services. And looking at that professional level of mix, we might sometimes say it's the most neglected public health problem, because if people are not trained, they cannot address the issues in the way we want to address the population. So this is a critical gap. Basically, this critical gap is created by a number of reasons. Probably the major ones might include the whole issue of limited production capacity. And in a very low-income country, probably priorities might be given to other different sectors, and this specific sector may not get the needed amount of resources really to produce the number of health workforce which can really address those issues. Again, another huge issue with low-income countries relates to migration of health workers within and across countries. Within, probably migration from rural urban, migration from hard-to-reach areas to the cities. That affects a lot, but at the same time, the brain drain from a low-income country to middle or high-income countries is also another factor. Again, poor mix of skills, because unless we have that mix of skills, which I feel like the integration plays a major role in bringing about that mix of skill, and a lot of socio-demographic imbalances such as region, which I raised it earlier, place of work, it can be urban, rural, and sex, in terms of who is preferred to provide those services, might have a critical role in terms of the reasons for those gaps. One of the indicators used by the World Health Organization to measure the health workforce need and the health system resource situation in a country is the health worker density, the number of health workers per 1,000 population by the type of health cadre, which can really show us really how much providers for the different levels of health cadre are really there. When measured systematically, this indicator provides information on the stock of health workers relative to the population. I'll only take two examples, next slide, to show the health worker density among physicians and nursing and midwifery personnel. As you can see from the density of physicians in most of the low-income countries, most in sub-Saharan Africa, few in Latin America, and also in Asia, you can see that the physician to population density is below 1 per 1,000 population. Next slide, which is also almost the same for the nursing and midwifery personnel. Again, in the same places, probably the figure you see in Latin America for the physicians looks a little bit better than for nursing and midwifery compared to the nursing and midwifery professional. So a lot needs to be done in terms of that one. I think looking at the minimum threshold density expected to be around 2.3 per 1,000 health professional is not fulfilled in most of these places. So the question comes, what should be the strategy into that one? Well, this indicator can be used to monitor whether for example, the size of the current workforce meets a given threshold that should allow the most basic levels of healthcare coverage to be achieved across the country. It's easy to measure this indicator and give a quick view of the situation of countries, which can also be used for a lot of planning purposes that even include the whole issue of human resource for health development, development of other important areas which can solve that one. However, this indicator probably doesn't necessarily take into account all the health system objective, particularly with regard to accessibility, equity, quality, and efficiency. So we need to see beyond that, which might need additional indicators to see the distribution of health workers by probably occupation, specialization, region, place of work, and so on. That's why when I earlier mentioned in terms of the oral health professionals, probably we can say like, it looks like the neglected side of the public health, specifically in low-income countries, which we need to do more into that one. Coming to my own country, Ethiopia, even though the health workforce density has doubled in the past 10 years, as you can see from both slides, this one and the earlier slide, Ethiopia is still in that range of less than 1 per 1,000 population, the ratio. We still have the problem of that, and understanding the health workforce shortage and in reaching the health sector and development goals, the country has taken several measures. And for your information, coming to the oral health workforce in Ethiopia, probably I can say one of the lowest in the world, and most of them are either in the bigger cities or in very few peri-urban areas, when close to 80% of the population lives in the rural area. So one can clearly see even those limited number of providers are staying in very few parts of the country when majority of the population lives in different places. So what are some of the activities which has been done in the past few years? Next slide. One major initiative is the increasing access to health services through the flagship community health extension program in Ethiopia, where you might have heard a lot in terms of changing specifically the maternal child health indicators in the country. This program at the community level played a very crucial role. Basically, the community health extension worker program deals with promotion, prevention, and primary curative activities, where oral health has a major place to be integrated if you really use such platforms in terms of integrating those things there. Again, increasing the production of health workforce, not only at the community level. Probably to give you a little bit, the community health extension workers are trained for a year after they finish their high school, and they will be assigned mostly in the places where they were born or grow up for to serve in a community of like one health extension worker for 500 households, which means two on average for each village. And currently we have almost close to 40,000 community health extension workers. These are not volunteers, these are paid by the government, which clearly gives you the opportunity that someone is there at the community level to be a primary contact in terms of the health services. In terms of the other health workforce development, increasing the number of health science college, both public and private, including dental schools in this both public and private places, increasing the number of specializations areas of training. Dental health or oral health is one, in line with the required demand in the country. The other activity is development of human resource for health strategy, which is responsive to training, deployment, and retention, and program structures, because sometimes it's not only necessary to train health service providers who are providing the services in the front line, but you also need to see the program structure. So having the NCD unit at the national level and at the lower level is also another progress which is there. Again, increasing access to primary level care through the expansion of primary healthcare centers and also primary hospitals. And a modest increase in referral and specialized care hospitals is some of the things which are there. With these major initiatives, progress has been made in the past few years, but more needs to be done to bring about better outcome in the health of the country's population, including oral health included into that one. When we talk about integration, I feel like some of the specific activities which are probably being implemented and will also work in improving the integration of essential oral care with primary health care includes, first of all, when we think of providers, training a dentist may take a longer period of time, but can those people, close to 80% of them, live in the rural area? It also varies in the different countries. Wait until we train a dentist, the disease will not wait for them. All those things are still there. So we need to do something into that one. So the whole principle of task shifting, task sharing is a rational redistribution of tasks among health workers, teams in which specific tasks are moved where appropriate from a highly qualified health worker to health workers who have fewer qualification, but trained to do the job. It's not simply transferring one thing to the other without really looking at into the whole issue which is there. Basically, this transfer is helping in terms of to make more efficient use of the available human resource for health until we have like what is required in terms of a high level trained person into that level. But if we look at most of the things, even from the previous presentations from Professor Mahesh from India and my good friend Professor Shu from Taiwan, basically, like there are a lot of things which we need to do in terms of promotion, in terms of prevention, where we may not need a dentist to do those activities. So integrating into the primary care will help a lot in doing that one. And this is where essential dental care can be provided at the lower level, where community members can get the right care in the right time and place without going to long distances to get the service of the dentist. We have several examples of tasks sharing, task shifting in the areas of maternal and child health, HIV/AIDS, mental health, eye care, and surgical interventions by training what you call it, integrated emergency surgical officers to provide those services in places where we might not get surgeons in a very short period of time or in an easy way. Another important area is the educational strategies, where reforming training curriculums to respond to local context and serving the underserved. One important area to look here is like integrated trainings, and also the whole issue of on-the-job training, because the whole issue of looking only trainings at the pre-service or higher training institutions might not be always the solution, specifically in low-income countries, and we need to see different training approach. Strengthening financial and non-financial incentives, because not everybody will go to those remote areas. So do we have strategies for those remote assignments? Someone working in those remote areas can get better opportunities in terms of education, maybe a short length of stay in those remote areas where it can encourage others also to serve in those places. Educational opportunities, limited assignment period, top-ups, different approach can be used to see into that one. Again, the continuous professional development is a very important area when we think of an integrated service in responding to those needs in low-income countries. Finally, all these activities and the different approaches cannot exist without a strong government commitment cannot be there without the existence of experiences in some of the initiatives. We're not saying task sharing shifting on the air, but there are really evidenced experiences which can be taken further also for oral health into that one. Again, commitment of development partners. Most health programs are supported by development partners in low-income countries, and that commitment needs to be there, which includes, I mean, when I say development partners, it's not only like donors, but we need also to see our own professional associations, the private sector, all this needs to be part of that one. Last but not least, we shouldn't forget the community involvement. I think any of these integrated activities, if we can link it with a certain level of social accountability, where community can be asking for their rights in getting the right services into that one, will also help a lot. But not only asking for their rights, but also, I mean, being part of the different development activities will make a great difference into that one. That's what I have in brief. Thank you so much.
Mengistu, thank you so much. That was really helpful. I just wondered whether you could just clarify, in many countries, one of the challenges is professional organizations, professionals who often resist in task shifting, particularly if that task is undertaken at what they would perceive as a lower level. Can you just give us some examples in Ethiopia of the barriers to the shaft shifting and maybe some of the solutions you found?
Thank you, Professor Rahman. I think as it's described, I mean, task shifting or task sharing is not an easy activity. I mean, there should be a well thought into that one. I mean, one of the barriers, you raised it well. I mean, the professional resistance is there. Probably, let me put one to additional barriers which can be there. In addition to like the professional individual or even sometimes professional groups, including associations, might be resist to some of these changes. But additionally, work overload is another barrier in terms of task sharing and task shifting. Another barrier, which I will come back again, is the whole issue of like the quality of care if it's not taught well from the right one. With professional groups or individuals' resistance, the first thing is how did we really address the issue with professional associations? One example I can give you is like when we introduced, I mean, a one-road implant for family planning activities in Ethiopia. Initially, we thought that this was only done either at the hospital or health center level, either by a nurse, midwife, or a physician. When you take it down to the community health extension worker, there was a great worry from the different. But one strategy we used is involve the professional associations from the start. Don't probably give them a final decided things. Involve them from the initial period. When you know that the number of professionals who can do that services are very limited versus the need for it, that's where you can really sit down and discuss what can we do in terms of that, where they will agree into that one. So the most important thing is involve them in the planning, including the development of different strategies, implementation guidelines, where their mark is there, they are part of it, and the resistance will be minimal. And one other important thing is, I mean, let's take the example of the dentist. If a lot of the promotion, prevention, and primary curative things can be done at the lower level, the dentist will be mainly involved into either high-level complicated things and will not have to be overloaded with minor things which can be done by anyone professional trained for that at the lower level. That's one. In terms of the work overload, when we look at task shifting and task sharing, most of the time what we see is every program wants to use available community level structure for task shifting and task sharing. So the first thing is, I mean, as I've already said earlier, eye care, mental health, everyone, if you are going down and using the same structure for which is there, we overload the single health worker, which is at the lower level. So proper planning is needed into that one. Sometimes we ask for a report which can be there in the different programs. The same type of data is requested by different programs. So by really working together with different programs, different healthcare areas, how can we really integrate, even when we do task sharing and shifting, is a very important thing. The quality of care, one important thing is, if we do a proper planning to do in terms of our task shifting and sharing, the quality of care can be improved by having the proper training, the mentoring and coaching, and the continuous professional development, which helps a lot in improving the quality of care. Otherwise, if we are not strong in our training, mentoring, and coaching, probably even beneficiary communities can lose confidence on the provider who is doing those services at the lower level.
Good. Mengistu, thank you so much. There will be an opportunity for all the panelists to do a Q&A after them, but I'm going to hand over now to Alan, who's going to introduce Bettina. I think I've got that right now.
Okay, thank you. Thank you, Dr. Rahman. And it is a great honor for me to introduce you my very good friend, Professor Bettina Borish. Professor Bettina, she is a professor of the social and prevention in the University of Geneva, and she is also the executive director of the Secretariat of World Federation of Public Health Association. Bettina, please.
Thank you so much. And good afternoon to those who are listening, good morning and good evening to others. I have the task to kind of sum up, and I think it is an easy task. Next slide, because next we have seen that there is a separation, and we all around the table or in this webinar, and I think a lot of you outside listening think that it's not only surprising that oral and general health are separated, but it may be dangerous in places, as we have seen from India, for example. And so we wonder how we came to this. We even listened to Bruce in the beginning saying, yes, the dental and medicine. So even in our own mind, we think of medicine, and oral is not, or dental is not medicine. We are quite brainwashed. So every evidence that we have heard so far tells us this should not be the case. We have seen from different places in the world, Taiwan, Ethiopia, India, Europe, it's worldwide. We are not the only ones. Everywhere there is this gap between oral and general health. We have seen that some local or national actions can help, can do something. But the question is now, can we do something on the global level, or haven't we done, or are we not good at leading the change? Next slide, please. Bruce also showed us the change theory of John Catter. We in public health have the change cycle. We say, first you have to have the problem. I think we know the problem. The problem is that we have an unnatural separation between oral and general health. We do have strategies, as we have seen, but we are not so good in implementation. Also, we have seen some good examples. So the question, besides these good national examples, would be, Who are the ones at the global level who should do something? Next slide. Who are the stakeholders for global action? Well, we first think of our neighbors here in Geneva, the World Health Organization, but we may think of other UN organizations, such as the International Labour Office, because they are the ones also defining professions and the limits between them. We also should think at this level of the global world organizations of our professional organizations. So the umbrella organizations like the World Dental, the World Medical, or the International Council of Nurses. For truly and surely, we heard it, especially now from Mengistu, the governments are to be held in account. And I think, last but not least, health is a human issue, so of human rights, we have to work together with human rights proponents. So let's look at World Health Organization. Next slide. Yes, indeed, World Health Organization already in 2006 in her World Health Assembly, where the 194 health ministers worldwide meet every year in May, has clearly underlined that oral health is a serious public health problem and that there is an action plan for prevention and integrated disease needed. If we are in the wording of the World Health Organization, you will always hear universal health coverage. That means universal health coverage, all people have access to the health services they need, when and where they need, and without financial hardship. So definitely oral health is part of it. Let's have a look at what WHO really tells us. Next slide. The WHO Global Oral Health Program now is integrated into the Department of NCDs, not surprisingly. As you know, when the UN meeting in New York was putting non-communicable diseases high up on the agenda, luckily so, in the last moment, oral health was part of it. And I'm very happy that they are part of the NCD's agenda. Next. And the oral health program of the WHO is clearly talking about the common risk factors approach with all the other NCDs. And it wants to integrate oral health into the modifiable risk factors such as diet, nutrition, tobacco, alcohol, hygiene, and lack of physical activity. But next slide, oral health, and here they come from WHO, is essential and has to be into an action program. And next, they give a priority to surprise the integration of oral health with general health programs at community and national levels. So all we have said is part of the WHO oral health program that also works like a lot of us around in the life course perspective, looking especially at those who need a special attention, like the young or the elderly. Next. And as we heard from also Shruti and others, this all is integrated into the big charters like Ottawa Charter, Jakarta Declaration, and so forth. So if this is all well said, and we are all thinking that should be done, next slide, where is it? Where is it going on? We have seen interesting reports from Taiwan. We have seen, thanks Mengistu, to something that goes on Ethiopia. But I think there are a lot of countries where what WHO asks is not yet done and not yet fulfilled. And I think that even our colleagues from the three countries, India and Taiwan and Ethiopia, would say there is still improvement possible. And I would come to, next slide, a word that has been mentioned already by Shruti, syndemics. Let's put health into a context. A syndemic or a synergistic epidemic is not two epidemics happening in the same time, or another word for comorbidity, but it means it is the presence of two or more serious, broad distributed disease states that adversely interact with each other, kind of creating a negative downward spiral for the population and speeding up the process that is going downhill, if I would say, for the health of the population. Next. So syndemics are especially interesting in NCDs for sure, but also if we combine NCDs with a serious epidemic of a transmittable disease, let's say, talk about Ebola, it will increase the speed of the downward spiral. And this holds true for both high and low income countries. There is no difference. It is just the fact that if we accumulate, it goes faster down the drain, let's say. Next. For example, if we look at some parts of the world, let's say the Eastern Mediterranean region, we have clearly seen that globalization has very quickly and very fast and fundamentally changed dietary patterns and the access to high-calorie food. And so we have an increase of individuals with type 2 and oral health problems, and especially in neglected populations. So we have a very, very fast trend. It happened faster than in, let's say, high-income countries of the common north. What does this tell us? Next slide. It calls upon us to do system thinking, to think the whole thing and not only our part. Even though we are all specialists, we are all good in one part, we have to think the whole system. Now on this picture here, you see the American healthcare system, and not only the American one, but all others are also linked to a money and commercial interest, and we shouldn't forget it. And we have to take into account the fact that healthcare systems are also money-driven systems. But we already heard from Mengistu that we have perhaps in the system one good possibility where we can start. And this is, next slide, what he told us about multi-professional work, task shifting, task sharing. The wording is different from place to place. We have a range of professionals in the healthcare sector, and we know by now that we will no longer be able to cover the burden of diseases worldwide and nationwide if we continue to work in our own professions without looking right and left and without having a team approach. The team approach sounds good, but as Mengistu said, there are a lot of hindrances. We heard from Bruce at the very beginning that yes, we have to adapt education. He talked about dual degrees, common curricula. I think this is very interesting and probably important, but I would also talk about the fact that our professions are somehow limiting us, and we should probably think more of competencies than only our professional cage or silo. But to do so, we need sometimes legal frameworks to be adapted. One example was from the US, where the CARE Acts in one state are completely different from the other's neighboring state. And this holds true in a lot of other countries where just legal frameworks for professions do not allow team working, teaming up, or task shifting. And for sure, we have to put incentives in place for the team to become a real team. Next slide. So is team still a dream? I hope not. I think it is not. But to make sure what happens at the world level, I was going through the websites and policies of the world professional organizations. Let me start with the policies of the FDI, the World Dentist Organization. Next slide. In their policy, a recent from 2018, they also say that oral health is an integral component of general health. So far, so good. And they also go to dental education, where they say dental education should include sufficient medical knowledge to fulfill the tasks required, because they say that dental professionals can do far more than take care of only the teeth. And next slide, they also have seen that there could be a change in dental curricula and that they could be reviewed in the inclusion of medical science in dental education. And again, you see here, inclusion of medical in dental, very deeply enrooted in our brains. Probably nobody looked at it by looking at dental is not medical or medical is not dental. That goes without saying. We just separate it already in our brains by using these different words. But for this part here, what is missing for me is that, yes, if the World Dental Association says we are going to integrate, I tell you, a team is not working like that. If I say, I'm a team, nice if you join and do what I do, I think we will not make up a very good job, let's say. Next. So I looked at another website, the International Federation of Dental Hygienists. Yes, they see clearly in their policies that they are important, especially for prevention and promotion, but they also talk about the interdisciplinary healthcare teams. So they are more open, let's say, to the team building that is needed. And before I start to go through all these policies, where I think sometimes the main focus is still on the profession and not so much on the team that is needed, I would like to come back to the Taiwan Declaration, next slide, that has been very well introduced by Shruti already. In the Taiwan Declaration, there is one point that should be mentioned. Among all the activities that also Bruce listed at the beginning, this one is the first time that a World Public Association and a Dental Association together wrote and shaped this declaration. And clearly, we know that we only can go ahead with teaming up if we have the government and the society together. And that we also, like Mengistu showed it very well, have to do it from the planning of primary health care already. And that's where we can already start before we have a super curriculum that will then give rise to a perfectly built up professional again. So what I think is also very important in the Taiwan Declaration, not only it is a joint venture between public health and dental professionals, but also it says that we are at this syndemics of oral, general, and social health. We see crises coming up, like in the US with opioid crisis. We see that the public health education training policy development actions, evaluations have to be seen in a system. If we are not doing it, we will see fast and faster worsening situations. Bruce also mentioned in the US, lack of access, lack of coverage in some places. If we are not doing the actions together, we are stuck, as he said. So, next and last slide of my resume is, what could we really do? Ways out. What is the practical thing tomorrow? I think we all could work more interprofessional. We can start on a small scale level. I teach at a medical and a dental school. In both sides, I mentioned the other side. Nobody prevents me from doing so. It gives sometimes a little bit of surprise on both sides, but I think we can do it. A lot of us teach in nursing schools, why not make sure that the knowledge goes from one profession to the other? Start the discussion there. Start where you work actually. We are well aware of the common risk approach. We repeat it like a mantra, but I'm not sure that it is known to all the health professionals you're working with. And I think it's worthwhile to come back with it, to underline it, and to mention it wherever possible, and not to be forgotten. And I think that those of you in the dental care who take care of children, or especially the elderly, know how important the social determinants of oral health are. They will show you how much we need the integration, because these are the people who need us most. And then I would call all of you to political action. That does not mean that you have to become a member of a political party tomorrow, or that you have to run for president in your country. I think political action is far broader. Probably you're all member of a professional association. I am member of several professional associations. And why not bring the topic up there? Why not enter the discussion in your professional organization? It is a small level, but it is a start. And yes, and now comes a tricky point, we have to change the incentives. Those who are living well with the actual system are not inclined to change it. I think, Mengistu, you mentioned it also, but there is no way out. We have to put incentives into the direction where we want to go. And last but not least, if we fail, health is a human right. Every human being on this earth has a right to health. And we have to be solidary and not think of us as the medical profession, but of those who we're serving. So I'm calling for solidarity with those we serve. Thank you. Last slide is for all of you. Last slide, please. To say, yes, Geneva is greeting you. Thank you for listening.
Thank you, Bettina. Thank you very much. It's very impressive, especially in the Taiwan Declaration. Yes, you have mentioned a lot. Yeah. Thank you.
Good. Well, thank you, everyone. I'm conscious of the time, and so if we have the next slide on the Q&A, just let me say that 3 times more people are watching this webinar than they did in the past webinars. And I think that's a reflection of the fact that this is an important topic. And in the questions that are coming over, nearly everyone is saying that it's self-evident that we should integrate. Mm-hmm. But the challenge is how. So many of you have covered that. So I wonder whether, starting with Alan and then just giving all the speakers a final say in what would be the next step for us as a global community or as a national community to take this agenda forward. Alan, do you want to start?
Okay, yes, thank you. Thank you, Raman. I think all of us, we would totally agree with that. We should integrate the oral health with general health. But I think the problem is for those non-dental health care providers, educators, and public health specialists, they are not generally familiar with oral disease and their effect on general health and a person's quality of life. And this has perpetuated an artificial separation or a gap of the mouth from the rest of the body. So I think maybe because we should have begin from the education. Maybe for those dentists, we should learn more about systemic disease. And in the other way, those physicians, during their continued education or during their education, maybe they should also install some dental disease in their curriculum. That's my idea.
Good. Thank you so much. Shruti, can I hand over to you with what would be your final remarks about things that we could do in the short term?
I think we all agree this is important, but as Bettina mentioned, what's our political approach? So I think we link with the global priority issue. For example, non-communicable diseases is currently the UN and WHO's major concern. So we link with the priority topic and we visualize the missed opportunities. How if oral health and general health can be integrated, how much improvement we can generate in the reduction of premature mortality from NCDs, we can help. So I think we link with the priority topic, we show the missed opportunities. And the third thing is to, we need champions and to persuade everyone that this can be done. And by doing this, it's truly helpful for the whole picture. Thank you.
Thank you. Mengistu, can I hand over to you? What would be your parting words about how we can take this agenda forward?
I mean, from the different discussions, I can say that it can be done. And there are already, although small scale, experiences which are there. We might not have like a magic bullet to recommend that it should be done in this way, but we need to see our approach in line with the local context. And I probably want to take the word from Professor Shruti that we need to have champions in doing these activities where they can be models also for others.
Thank you. Bettina.
Yeah, I think we are and we have built our own cages. Some of the cages are golden, some are less golden, but it's up to us to break them down. And I think it's Bruce who has done something in Rwanda. Every place will have its own and local way of doing. Sometimes it is easier to do something from scratch where there is not too much system and not too much rules already around. I think in this case we will have to learn from a lot of the low and middle income countries who find creative solutions and try to bring them back to high income countries. I would say that we work with our governments, but they cannot do everything on their own. We have to be open to also give up privileges, and the team working will hurt perhaps at the first beginning. Who wants to give up anything? But it hurts only a short moment, I would say, like the dentist says, and then you feel much better. So that would be my last word, because we have no chance to do anything else. Thank you.
Good. Well, thank you, everyone. Can we have the next slide, please? So my role is to give some take-home messages. For me, I think all the speakers have highlighted the central premise that integration is good. It does not dilute quality. And even with task sharing and transferring of some tasks to other groups of the healthcare professionals, only enhances the quality and the appropriateness of that care. Integration also is important not only for low-income countries where workforce is a challenge, but in high-income countries. And it can be summed up with many people have said in the oral health context, we need to put the mouth back in the body. Every dentist who looks in the mouth has to remember the impact it has with the rest of the body, and of course everyone looking at any aspects of health, and it has to remember that the importance of the mouth and the mouth plays. So putting the mouth is very important. All our speakers have highlighted the importance of political engagement and also for community engagements as well, fully understanding the tasks that need to be done. For me, all that is summarized in the fact that we need to develop leadership skills in all our professions, because it's only through good leadership where we'll bring about the change. All this has been summarized in April 2019 in the Taiwan Declaration. And we commend that to all those who are listening to this webinar, that the declaration actually puts together some of the framework that's going to be needed and the issues that people have raised to bring about better integration of oral and general health. So we commend actually all our speakers, we commend to you now the Taiwan Declaration, which I think actually captures the nature of the importance of integration and the steps that are needed to make sure this becomes a reality. I'm going to hand over now to Alan to thank all the speakers and to formally close this webinar.
And thank you, Raman, and thank you for the speakers. I think it's very important for us to step forward, because as a dentist, I'm very glad to have this opportunity to participate in this kind of webinar, because the goal to integrate the oral health to the public health, I think it's a very important for us. As reported, as presented in this webinar, 57.8% of the patients with cardiovascular disease, they come to the clinic, dental clinic. So how the dentist can be ignore what is cardiovascular disease or other systemic disease. So I think it's very important to integrate the oral health and public health. And so in the other way, so the physicians, they have to be aware of the oral disease as well, because most of the patients, they go to the physician's clinic, they suffer from some problem of oral disease as well. So that's my idea. Thank you very much.
Yes, it is. Thank you. And thank you for co-chairing this webinar. It would be amiss of me not to highlight that the Taiwan Dental Association have specifically sponsored this, this webinar. And although the University of Geneva and the Global Child Dental Fund and Colgate have supported all our webinars, this specific webinar was only possible with a grant from the Taiwan Dental Association. So we thank Taiwan. We thank you for putting the declaration very much on the roadmap of the integration agenda. And so with that, I now formally close this webinar, thanking everyone.
Thank you. Thank you. Bye-bye.
Bye-bye.